There we go. So welcome to the Research Lounge. So this Research Lounge has been titled "What is Big Data?" and Demystifying the Use of Healthcare Data in Research. We have got a few speakers lined up for you this evening. First of all, we have Esmond Irwin, who is a research data analyst for Nottingham Biomedical Research Centre, and he's going to talk to us a bit about how is health data used for research purposes, why is it important, and what are the benefits of this. After that, we have Professor Guru Phao, who will be talking to us about a specific research study looking at multi-organ fibrosis and data that is used and why, again, that is important. And then finally, we have Chantal Kwame, who is also in the Gastrointestinal and Liver Biomedical Research Centre, and she will be talking a little bit about some ethnic diversity data and why it's important we get that as well and use that for research purposes. That's enough from me. I'm going to pass over to Anthony of our double acts just to run you through some housekeeping before we get into the exciting stuff. So over to you, Anthony.
Thanks, Kate. You actually said half the things I was going to say, but never mind. So as Kate said, we'll record the session so we can share it with people who couldn't attend, and it will be uploaded to our YouTube page. And obviously, as Kate said, you can keep your camera off if that's more comfortable for you. In terms of the way that we'll run this, if you do have any questions, if you just raise your hand, then we'll find an appropriate time to stop for you to ask any questions. But there will be some time at the end of each presentation for questions and answers anyway. So if you can hold off, please do so. We've also got the chat function as well, so if you are more comfortable typing your question out, then please use that. We'll come to those at the question time of the event as well. And if there's anything that's unclear or that you don't understand, let us know. We can try and make things clearer for you. Yep. So we'll start with our first presentation. So I'll hand over to Esmond to kick us off.
Good evening, everyone. The hardest bit of the night, sharing my screen. Fingers crossed. Right, can everyone see?
Yeah, that's perfect, thanks.
Yeah, is that all good?
Yeah.
Excellent. Well, good evening, everyone. I hope you're all well. My name's Esmond Irwin. I work at the School of Medicine, University of Nottingham. And I'm going to talk about what we do with health data in research, give an overview of some things we get up to. Look at data. It's everywhere nowadays, isn't it? Why we use medical data, benefits of, etc. Fair. I'll get into that accordingly soon. Something called the Coconut Project, project I worked on during COVID, COVID-related project. Some safety aspects around data, namely 5 SAFEs framework.
Progress.
And then summary at the end. Okay, so data, yes, everywhere, isn't it? Here we go. Here's a wide-ranging view of the ever-increasing amount of data that exists and will exist over the next few years. As we can see, healthcare, 36% growth over this range, this seven-year range. So just looking at what's uploaded every day to YouTube, relatively inconsequential stuff, health data, which is incredibly important, is growing at an increasingly large rate. But that brings problems. How do you keep track of it? How can you innovate? How can you use it in different ways? It's all very well recording this data, but what are you going to do with this data? Can you gain benefit from the data? Can you develop different medicines, different treatments, focus on patient outcomes, and try to use it for the benefit of people, and try to save lives, is surely the ultimate aim of this. So we look at, in my line of work, we look at identifying data, representing it, cleaning it, structuring it, and making it fair. So we try to make things findable, accessible, interoperable, discoverable. So not just human to human, computer system to computer system, make it reusable. So, few too many words on this slide, forgive me, but I think the picture says it all, really. An ever-aging population, multiple morbidities, so multiple conditions that people live with as people get older, population growth. Therefore, how can we better understand diseases? How can we develop new medicines? How can we personalize treatments rather than making one size fits all? Surely we can develop different treatments for different diseases, or a combination of diseases for different people, different ethnicities, at different stages in their lives. And of course, as technology comes into these things, try to integrate technology and data into care to improve it for all, to make quality of life better for everyone where possible. And then something that I'm not personally involved with, but algorithms for safer care. As we start to use more technology, it's important to understand how we can better serve the end user, i.e. the patient. So these things can be used to help develop algorithms such as that. Okay. So fair. This is a lot of my work based around. It's all very well having all this data, and there's a lot of it for every patient within the UK. This can be used for the benefit of people. There are concerns about that in terms of security and safety, but I'll get on to that in due course. But if you want to use people's data to develop better outcomes, develop new medicines, develop new vaccines, let's say within 100 days for just like COVID, you need to be able to understand what data is where, who has what. When you find out where it is, can you access it? Is it reusable? And is it interoperable? Is it in a very one-off, concise computer system, or is it something that can be used between multiple computer systems? And this is what a lot of my work focuses on. Which leads me to the Coconut project. This is lots of some really good videos on this website. We had a patient public involvement group within this project, 2-year project, started in April of 2020. So literally worry, about 3 weeks into the COVID pandemic, was focused on COVID data, and it was looking at how can you find and access data and then potentially reuse it. So generally, researchers will, before this system was developed, would have to email potentially 100 people, maybe more. Have you got data around, let's say, asthma, as an example? And then that email might be replied to in 2-3 weeks' time, by which time that person at the other end who has potentially the data you might want says yes, and then you email again, okay, could you tell me a little bit more about it? Does it have X, Y, or Z within it? So an incredibly laborious process that could take 6 months to a year to understand. Has somebody got something that I could potentially use? What is within it? And could it aid research to develop a better outcome, vaccine, etc., for a given disease? So Coconut wanted to build a system whereby researchers could find data, i.e. who has what where, not access the data, but understand where it is and who has it. There's a big difference in that. So the problem we have with data, a lot of data is in different formats, and I'm sure everyone here understands. Right in the midst of the pandemic, myself and some of my colleagues were asking doctors, nurses, through a computer, through Teams, through a web call, asking nurses within wards who were fully kitted up in their PPE, could we have we would like to understand what data you have, which was quite difficult at the time, considering they were dealing with a COVID outbreak and we were in lockdown. So a lot of people were capturing data as best they could on bits of paper and Excel in different types of databases using different bits of software. So the problem we have trying to represent this data so it can just be discovered, not understand what's within it, but let's say Professor XYZ has a data set on asthma in Leeds, and Professor ABC has a data set on asthma in Plymouth, but they're all named differently. One's on paper, one's in Excel. It's very difficult to compare these data. So a lot of my work is trying to represent data in a standardized way. And we use this, we use healthcare data codes. So an international data standard, we convert them to represent the original source data. And by converting to standardized terms, so something called SNOMED, so that's standardized nomenclature of medical terms. So we represent data set A with SNOMED codes, we represent data B with SNOMED codes. Even if one was in English and one was in French, we could do this using a healthcare data standard. That enables comparisons to be made between different data sets, although they might be represented at source within a hospital in a different way. So I beat myself to the punch. Here we go. So format, something in Excel, something called cough, a symptom, quite a very, one of the key aspects of COVID was recording who has a cough. Is it a dry cough? Is it a wet cough? And as you can see, the standardized term. So 254761, that is the SNOMED International Healthcare Data Standard Code for cough. So one could be an Excel spreadsheet, one could be an Access database, one could be in an SQL database, named differently as here. You can see, so cough 001, symptom 01, question 1. Although only the person or the people using that data set within a specific hospital would know that that's quite an obvious naming, but symptom 1 is not necessarily. Anyone externally wouldn't. There's no clue as to what that means, and the same with question 1. When we represent it with this code, it is clear and unambiguous that that is a cough. And that's how we, a lot of my work in representing data so it can be discovered. And what that means is, rather than emailing people for 6 months to a year, you can literally, once you've represented these data sets using these codes, you can find them within minutes rather than 6 months to a year. So how is it done? It's done by way of federation. Federation means the data stays where it is. You don't bring all these data items together in one big pot on a big server, let's say, somewhere in London. Its data stays where it is. So if it's in a hospital in Leeds, that data stays in Leeds. If it's a hospital in, shall we say, Leicester or even Nottingham, it stays in Leicester or Nottingham. And what the beauty of this, it's safe and secure. We don't have to ask for access to the data. All the data owners control their data. We don't need access to the data. Ironically, one of the biggest problems we had was for asking access to the data, but we actually didn't want access to the data. We were focused on metadata. So what this brings about is something here. This is the Health Data Research Portal. And as you can see here, we've got a set of conditions. So we have person, female, and male, that's sex assigned at birth. We have things like medications, some conditions here, many of them. I'll press play, and you can design a query graphically, so you can drag and drop a query. And this one, as far as I remember, is so asthma, you type in asthma. You can see it lists asthma, you can build a query. So that is, query is something you can design. Asthma, males, and it will ask the system for all the different data sets around the country that exist in it. Could you please tell me those codes around asthma that are male? And it will run for a few seconds. So this is not 6 months or a year and 100 or 200 emails. If I just jump ahead, it will return values, so accounts. So we've got about 3,200 counts of personal records, range of ages, and as you can see here, it's just for males. So it's a very useful system. And this is for discovery. This is not for access. All items within are anonymized or pseudonymized. There is no personally identifiable data, so things like dates of birth are rounded or an age is given. There are no postcodes. All these highly sensitive aspects are removed, and it focuses on the conditions, where the data set exists and how you can access it. And then what this enables a researcher to do is to directly ask the data controller at a given place, could be hospital, could be somewhere else, could I please have access to your data? And then we come into something around safety, something called 5 Safe Framework. 5 different aspects, approaches to safety for health data. Safe people. Are the people asking to access the data, are they safe? And there are conditions around these. They have to be a researcher with a track record. They have to be trained in statistical techniques. So some training courses from the Office of National Statistics are provided, and we ask these people to be qualified with those. They have to have a degree in a certain subject for us to understand. And then what we have are safe projects. So projects are assigned. Data owners allow projects to have access to their data, and both for safe people and safe projects, one of the underlying questions is, why do these people want access to the data? What is their purpose? So random people cannot just sign up and access. There's a whole governance approach to this. So only those who have the correct foundation for doing such research, have the evidence to prove that they are who they are trained in certain ways, can then enable them to gain the title of a safe person. Safe settings, so physical and virtual environments. There are things called safe pods within the UK. There is one at the university. And if you are a safe person on a safe project, you can enter these effectively lockdown environments, physical environments that you go into with no mobile phone, no laptop. You have a built-in device that you log into. You cannot just print out or take away data. The data stays within that lockdown environment. You can undertake analyses within that environment, but you can't just walk away the data. So it's an incredibly safe way to access data, enables data controllers and data owners to understand who's doing what where, because everything's logged, and only people with the right conditions can enter such places. We have safe data as well. So confidentiality is everything. Data is anonymized, pseudonymized. Things such as date of birth, like I've said, can be rounded. Rather than have date of birth, you can actually just have age. So it doesn't give away the specific date. Postcodes, addresses, email, and such like can be removed. And we use something else called a minimum count. So if you have a set of data, 100 people with asthma, but one's only called Esmond, I me. If there were 10 people called Esmond and the minimum count is 10, and using this just an example, then it would say within the data, yes, we have 10 people, obviously not me, Esmond, but we have 10 people that have asthma, let's say in Nottingham. But if it's just me by myself, the minimum count being 10, just because there's one, it will not count it and it will not report it. So we try to minimize identifying a person by minimum counts like that. And then safe outputs, it's all very well going through all of these things to minimize everything. But the actual data that comes out for research for people as part of the 5-stage framework, everything that is output is reviewed by people who control and check the data. So there we go. Really, at the end of the day, we're trying to develop things for people and their health, save lives, new treatments, diseases. Right, okay, there we go. I think we've gone about 2 minutes over, so forgive me.
Don't worry, forgive you. Thank you so much, Esmond. That's really interesting. Oh, that's me. Sorry, did you say you had a video?
Yes, there's a button. I found a button. There we go.
There we go. No, but thank you so much. Has anyone got any questions? And I'll reiterate, our mantra for these sessions is no question is a silly question. We encourage them. So has anyone, anything that didn't make sense?
Yes, can I start off then with a lovely one? Can a person opt out of sharing their data?
Yes, it's your data.
So there is an element of consent.
I'm not a legal person, by the way. I'm a data engineer.
Right.
There are legal frameworks whereby data can be used.
Right. So I'm assuming then, sorry, I'm assuming then that a person, their data is used unless they say they don't want it to be used.
Not necessarily.
Sorry to throw that one at you.
No. I've been waiting for this all day because this is a very tricky area.
I'll tell you where I'm coming from. Obviously, I'm senior in years, and there's a lot of us elderly people very aware of things like scams and identity theft and what have you. So when it comes to sharing your personal data, I think we're all a bit nervy, if you like. So hence my question. Sorry.
No. There are legal clauses whereby data can be used without consent.
Right.
Generally, those are not used, and that's for most of the work I've done has been focused on research cohorts. So the people that submit the data consent for their data to be used. I have some colleagues at the University of Dundee that work on longitudinal data sets. So data sets usually within hospitals that capture data over time for a given patient. And sometimes they are not consented, but you have to follow a legal path to use data if it is unconsented. My focus is on research cohorts, which if the person has consented, then we will use the data. Well, not will, we might use the data. Let me rephrase.
Right. Okay, I'll let someone else have a go.
No. I've been focusing on COVID data sets.
Right. Okay.
So I think about 20 different COVID data sets from the UK.
One of my things I'm worried about, and I've been looking into this, there's an outfit called Oprose UK, Health UK, which is owned by an American company, Centene, and they operate 70 GP surgeries with over 600,000 patients. Now that data is accessible to America now, theoretically speaking, and I've just heard that Centene now want to sell that off, all their UK healthcare operation. Now, obviously, they're going to go off to the highest bidder, and it could end up being Saudi Arabia, China, Russia, anywhere. And that really frightens me.
You're talking to someone who's you won't find me on social media. It's not what I do. I'm always extremely careful with my data myself. Think about it. Every day you log in to a website or you open up Google on your computer. I know I can't see you, but hands up who clicks accept all cookies.
Yeah.
Because you are giving your data away instantly, because those cookies record your machine, your IP address, where you are in the world. So it's the whole issue of data and sharing data is actually quite ubiquitous.
Yeah.
But then there's the sensitivity of data, and I do understand. It's an incredibly fine line to travel, I feel. Without access to data, you wouldn't have got a COVID vaccine within 100 days, give or take. So,
Fine, thank you.
it's ethically, there's no black or white, it's all grey, as with most things in life. Nothing's simple. But yes, I do understand the concerns.
Thank you.
Yeah, thank you, Richard, for your questions and for voicing those concerns, because I think that's what we want to hear as well, is what are your concerns about this? Because we know, I mean, I know what mine are, but it's kind of understanding other people's, and then, you know, to best answer the questions as well. And we are speaking about data for use in research, and there are very robust processes in research generally. So
everything I've shown you today uses metadata.
Right.
So me as a data engineer, I never see any data. It might seem odd. I'm interested in the structure of the data. So let's say you've got an Excel spreadsheet. You've got 20 people in that spreadsheet, and let's say they're going on holiday. So what date are they going on holiday? Where are they going on holiday? When are they going to have lunch on holiday? What are they going to have for lunch on holiday? For those 20 rows, I don't actually need to know anything, and I don't actually, more importantly, I don't want to know.
Yeah.
Me as a data engineer, I'm looking at those headlines. So date, holiday destination, lunch item. That's all I ever see as a data engineer.
Thank you.
And this whole discoverability thing, it is not. Everything's anonymized, and it's about showing what people have in terms of metadata. So Dr. ABC in Plymouth has some data about asthma. In their data, they've got some symptoms, some dates, what the symptoms are. So a cough, breathlessness, things like that. There's no actual data within this tool because it's all removed. And if a researcher finds that, says, oh, wonderful, Professor ABC in Plymouth has an asthma data set that records cough, breathlessness. That is the function system to show who has what where. But in terms of actual row level, detailed personal data, it doesn't actually exist in the system. So there's no way you can ever get access to it, because the whole access, that researcher then has to go away outside of the system and individually go through a data access control procedure to ask that data owner, I am researcher XYZ, I would like access to this data, I would like to use it in my research for ABC. And then it goes through a whole governance process at that hospital to understand who that person is, what their need is, why do they need this data, what is the benefit, and what are the proposed outcomes. So this system is just to highlight things like that. There is no data in the system, it's just metadata.
Brilliant. Thank you so much, Esmond, and again for your questions, Richard. And Hillary's put a really interesting comment in the chat, and I'll encourage people to carry on because this is a good debate and theme of discussion. It has been for a long time, even more so probably now. And I think COVID highlights the use of data when you have a lot of data and specifically diverse data, what you can do with that for patient benefit, for healthcare, which is what we'll lead on to with our next presenter as well. So we're kind of covered, and thank you, Esmond, again. Thank you. I really appreciate it. So any other questions, and put them in the chat, and do our best to answer those. If we don't tonight, we'll keep them so we can ensure we circulate any questions or any themes that come out of the chat. But now we're going to move on to our next presenter, who is Professor Guru Afal. He is our lead. He's many things. I'm not gonna lie. He's our lead for a GI and gastrointestinal and liver theme of our Biomedical Research Centre. But for the purpose of tonight, he is going to talk about a very exciting research study, which is looking at identifying multiple organ fibrosis, and specifically going to look at an overview of the study, but then we're going to look in more depth about why using patient data is so important to understand this and for the ultimate outcome of patient benefit. So that's enough from me. I'll hand over to yourself, Guru, if that's okay.
Can you hear me?
I can, yes.
Yeah. And can you see the slides in an appropriate way?
We can. It's come up perfectly.
Okay.
Yeah.
I'll be talking about study which is briefly called Demystify. If you look at the details, it is defining mechanisms shared across multi-organ fibrosis, which I'll explain what it is, to prevent the development of long-term multimorbidity, which again I'll define and describe. So demystify, we are going to demystify the study, and we have already done that to the title. So this is a real life scenario. I saw a person, 50-year-old man, who presented with ascites. Ascites is collection of fluid in the tummy. This is common in my practice. When liver doesn't work, body starts accumulating fluid. A person also had shortness of breath on exertion, and he had some excess alcohol consumption and hadn't drank for 2 years. But what he described was that his brother had been under my care, and he had what we had described as non-cirrhotic, means that cirrhosis is scarring of the liver, which I'll show you in a minute. He didn't have cirrhosis, but he had portal hypertension, which generally happens by building of pressure in the circulation to the liver. Usual cause is cirrhosis. So there are causes of building this pressure without cirrhosis. So this is unusual and not a condition which generally goes purely by genetic basis, one-to-one. In other words, it's not a genetic disease, but all the conditions, health as well as conditions we have got some genetic predisposition. But this one looked not that kind of thing. So we looked up and did some genetic tests and found that he had a variation in a gene called TERT. So on the right-hand side, I've kind of summarized what this is. If you think of organs, cells really duplicate all the time. And each time cell gets injured and it kind of regenerates. Liver is one of the organ which regenerates very, very well, which is a good thing. It tolerates a lot of insults we do for the liver, but it needs really this cap. I have put in a chromosome here, which has got a blue and then a red is the cap on 4 arms of it. One is a short arm and another long arm. And that cap is very important. So there is a system in the body which is called a telomerase, an enzyme which creates some extra DNAs and then adds to this cap so that it's retained. And if these genes have got some variation in them, then the cap doesn't really get formed. And so the cell or the organ fails to regenerate as much as one would expect. And that is how we also age, because you can see the billions of times many organs and cells would have duplicated. And its natural process is some wear and tear to this cap, and the system which repairs it doesn't work, then one ages a bit early. So this person, unfortunately, had a variation which is rare, and the group of these conditions are called telomeropathies. He had one such variation, and this is how the idea of the study as well as this grant was born, suggesting that maybe the organ aging might have a common reason behind it, unlike biological aging or a chronological aging. So coming to the liver, I'll use the liver as the way to describe what fibrosis is. Fibrosis is a process where normal mechanisms of the organs to fight inflammation leaves a bit of a scar. And then when the inflammation is persistent or recurrent, then the scar doesn't get time to clear up and then accumulate. So this is the smallest unit of the liver. There are multiple these things, but this is called an acinus. Can you see my mouse moving, marker moving? Yeah? Yeah, okay. So this is really hexagonal, and it's really beautifully designed, and this is exactly how it looks in the normal liver. I'll show you a slide of a normal liver or a histological section. So there are what are called triads. In each of these corner will have three structures. One is a hepatic artery, like all organs, blood from the heart comes to it. And then liver is the unusual organ, which has got two blood supplies. It's lucky. One of the blood supply comes from the vein, and that brings nutrition to the liver. So in a way, liver is the only organ which has got two blood circulation coming into the liver and one taking it away from the liver. So this is called portal vein. And then the liver also makes bile, which is one of the multiple functions of the liver to clear things through the bile, as well as produce some substance which helps to digest it. And that goes from the liver into this green structure called canaliculi. So these three things form triads. On the right-hand side, I just show you how things work. So blood comes from, on the right-hand side picture, I have marked it in a blue. Red is really artery where blood comes. And then blue is a portal vein. This is an extra thing which liver has got, also brings in blood, but this is nutritionist blood. And also in the liver's case, oxygen comes from two blood vessels. And it goes through these channels, which I have drawn here, and then exits this mini structure through a vein, like all of the organ, taking blood away. So you can imagine that blood first time comes into touch with these brown structures, which are all liver cells called hepatocytes. And so that is where it faces anything in the environment called antigens. These are all things which can cause inflammation because they can be environmental toxins, or like alcohol, what you drank, but it's not quite that much healthy stuff. As the blood flows to the central vein, you can see that more and more oxygen gets taken up from the liver cells. And as you come to the center part of it, more and more toxins or poisons are taken off from the circulation for the liver cell to clear. So this area has got most amount of poisons to clear because bile is one way it clears it, but least amount of oxygen because it's been used up from the travel. So liver has got two ways of insults. One is really if you have got any foreign substances which liver hasn't seen before, it can cause inflammation in this area. And then if you have got too much poison, it accumulates in a highest concentration in the central area, and that can be injured. So these are the 2 points where the smallest structure of the liver, acinus, gets injured. So inflammation starts there. What happens with the inflammation? This is now a cartoon, but almost like an electron microscopic picture of almost like a zoomed in version of liver cells. So these dark brown cells are the liver cells on either side. And I showed you the channel through the blood flows. This is a mixture of what has come from the artery as well as the vein. These are called sinusoids. You can see pale pink areas. And in between, there is a little space called a space of Dicey. There are really what are these star-shaped cells. You can see an octopus-like cell, which is now got activated because there is a bit of an injury. And that is always their quiescent way. it doesn't really look like a star. It's called stellate cell because it looks like a star when it gets a bit active. And it gets active when there is some injurious substance going through the circulation. And then it starts growing its tentacles and then starts covering these vessels. And then as more and more injury happens, this space gets occupied by these cells and they start laying down the scar tissue. Their idea is to contain the inflammation into a small area, almost like finding a wall for the fire. But if you have got persistent inflammation, regular drinking, for example, or recurrent inflammation, you have got a bout, before you recover, you have got another bout, then these don't have time to clear this space, which is body's job. And then over a period of time, you accumulate a lot of scar tissue, and then you completely alter architecture of the liver, almost like a channel where the blood flows. You can see again now that hexagonal structure. You can see these blue areas, which are these triads, and this is a normal liver. And then scars laid out make the liver look like this on the right-hand side. So the liver becomes lumpy. The connection of these blood vessels are all altered, and there is a scar tissue, almost like putting these cells into jail so that they can't really talk to others, to the neighbors. So this is what cirrhosis looks like. And if you look at the MRI scan, this is a special scan we developed in Nottingham just to estimate the amount of scar tissue. And I've color coded the resistance to the blood flow and then altered the blood circulation architecture as well as the scar tissue here. Blue is really healthy at the top, and then maximum amount of scar tissue is retained. You'll see all this orangey, yellow, lumpy liver. And this is how it looks. On the right-hand side, I've shown the pressure in the liver builds up. Normally, it's less than 6. You can see gradually as the liver gets worse. It's gone up to 7 now, abnormal. 13, where the problems start occurring. 22, you start manifesting with a problem. So this can happen in other organs too. So on the left-hand side, I've got a normal organs, liver and a heart and a kidney as an example. And you can see how the liver looks, which is nodular and lumpy. This is also looking like change in color and the stiff heart. And then again, a little bit scarred kidney. So this is really what we are addressing in this study. So this is a fibrosis is a response to recurrent or persistent injury or inflammation within most of the organs. And that can occur in the skin, or the heart, or the bone marrow, liver, gut, joints, eyes, lungs, pancreas, kidney. So multiple organs can have fibrosis. And till now, we have been focusing on individual organ fibrosis and looking at, why liver gets scarred or a lung gets scarred, and then focus on research on that. But our hypothesis is that, like this unfortunate family where the specific genetic variation explains scarring in the multiple organs, are there really more common conditions which overlap in individuals or cluster amongst people? Do they have a common pathogenic mechanism underlying with them, which we haven't really asked about, which we haven't thought of? And we want to ask that question in people with, starting with one of the organ injury, and then as the life goes on, seem to acquire another condition and another condition. We assume that these are coincidental, but is that something explaining them occurring together? So the reason is that it is seeming to be a common problem. This is the data from a Scottish cohort. I think it's what is called a West of Scotland coronary prevention trial data, which shows that by 65, half of the population have got 2 or more conditions. And it is assumed to be due to aging population. But by 2035, this will be common in almost like 2/3 of the population in UK, and may not be always explained by just aging population. So we are taking fibrosis as one condition in itself and trying to see, is there a common understanding, common underlying mechanism? One of the simple things we see is that common underlying mechanism might be risk factors, which we understand. This is one of the conditions called non-alcoholic fatty liver disease. About a month and two ago, it's been now renamed as metabolic dysfunction associated steatotic disease. So rather than MAFLD, it's called now MASLD. This is one of the cohort from US, where about 1,700 people were followed up for median, which is a kind of an average, 4 years. By 4 years, you start seeing that this condition is both affecting lifespan of individuals as well as other organ problems. So lifespan means that, all-cause mortality, whatever way people are dying, is more than expected from the population within about 4 years of follow-up. And right-hand side graph shows that this number, F0 to 2, means that small amount of scarring in the liver. F3 is advanced scarring in the liver. F4 is cirrhosis. And that determines how much extra risk they have got in having death from any causes. This is not liver-related problem they are dying of for any cause, which means that maybe there is something more to it just than liver fibrosis. Another point is that in the same way, more scarring they have got, more kidney function is deteriorating, which is not really explained purely by scarring, because it's not all cirrhosis. Even people with lesser scarring have got an excess risk of getting kidney problem, chronic kidney problem, which again might be related to scarring there. And they have got more risk of developing type 2 diabetes. Again, maybe something also going on at the same time in the pancreas, which we haven't really taken really serious look at, and we have assumed all the time that it's all related to weight gain or type 2 diabetes or something along the line. So our objective of this study is to identify clusters of multi-organ fibrosis. Multi-organ condition is a broad term. We are specifically look at some pathogenic pathway which actually focused on scarring in multiple organs. We want to find out how common it is, what risk factors are associated with it, and then really how does 2 or more organ scarring affects people beyond single organ scarring affects individual organs and people, which we already know enough about. Not everything, but sufficient. We also want to find out, can we identify some way of identifying a person getting another organ scarring and the third organ scarring when we know that they belong to this group? Is that any way of we find a trajectory for it so that we can be prepared for it? And then eventually, if you find a pathway, we want to find an intervention which can reverse it. I showed you that all this scarring have a potential to be reversed, but we need to really kind of find a pathway how we can target. So I'll give you some of the work which has been done, preliminary work that has been done. First of all, this is like a UK Biobank data. I hope you can see the title. I think this bar is coming up on the way there. If I just kind of take liver and lung, which is like a primary organ, so you can see liver here, and then it crosses lung here, 0.739. This number, 1 is like perfect correlation, coexistence, which means that this is like more than average chance that if you have got liver problem, which is scarring, you also seem to have lung problem in scarring. This is like a UK Biobank data, which is not an accident. And we have written here, right, the number of people in individual group we have seen. So liver has got 1,528 people, and lung has got 4,767 people. And if you cross them, they seem to have more than average chance of having another organ problem, which seem to be quite interesting. So maybe we have got a hypothesis which has got some truth in it. And these are the cohorts which we have collected or put together over the years, which we are going to study. So we are starting with 5 primary organ related fibrosis or scarring, which we have already enrolled through different ethical approval. These are all ethically approved studies which are already been done. I've got collected the data. You saw a term called FAIR in Esmond's presentation. So the R stands for reusable. So we have got now ethical approval to ask a different question. These individual studies have been drawn for answer a different question. And these patients have got given permission for us to use their data in a future research. But we are asking a different question. So we have got ethical approval to link these databases, anonymized already, and see whether there is any common answer to a question comes up when you combine these data sets. So liver fibrosis, inflammatory bowel disease causes intestinal fibrosis, chronic pancreatitis causes pancreatic fibrosis, lung fibrosis, and chronic kidney disease causes kidney fibrosis. So we start from individual these organs, and each of these cohort, we are going to look at, do they have another organ fibrosis or more? And then we put together people who have got 2 or more organ fibrosis and see, well, what is common between these guys? What pathway, what genetic susceptibility, what risk factor, what pattern of conditions and outcomes we develop. And this is roughly the way, I think probably Asmund will explain it better than me, but I'll tell you what we have ethical approval to do. You can see here the big ambitious plan, something which Demystify has committed to do, and something beyond that we are doing. I'll explain which bit is beyond that. So we have collected different cohorts data, as you have seen. And we would really, first of all, this yellow side put together, like I mentioned, and find out what proportion of people have got 2 or more organ fibrosis, and then find out what is the common factors which are underrunning these people in excess of what you expect by coincidence. And we would like to collect DNA from them. We will generate potential candidate genes which might explain this in the UK Biobank, and we want to replicate in them. But beyond that, here, we want to invite those who have asked us to, given us permission to invite for the future studies, and then follow up their progress, and then see whether longitudinally, in the long term, can we really get some trajectory for any new problems they develop. And this is the number of people who are in the individual cohorts. Each cohort has got about 1,000 people or more. Some are bigger than the others. Just preliminary analysis, just on a liver cohort, for example, shows 39% of them have got a second organ involvement. 5% have got a third organ involvement. And we envisage about 400 per cohort to be having, we have, I think, 4 of this cohort. We already have got a DNA, which they have permitted us to store. We identify 400 of them with 2 or more organ, and then put together about 2,000 people for replicating the genetic signal, which we have found in UK Biobank. That's the first thing we are going to look for. So we have got actually DNA in most of them. This is just one cohort I'm describing, but that is because I collected all this information. And we've got also serum and plasma. If you want to look at new biomarkers, We have got imaging, MRI imaging on multiple organs, again collected already. And some of them we have got even liver biopsy tissues where we can do sophisticated scientific studies. And I've kind of put up a graph of how you analyze the genetic data. This is what we call a Manhattan plot. So you can straight away recognize why it's called Manhattan plot, because it looks like Manhattan. And there is a x-axis, which is a different chromosomes. You can see the number. And there is about 1 million dots in this picture. Each dot is one variation in genetic sequence on an individual and in a population level, right? And then on the y-axis is a reverse of p-value. P-value you might hear all the time. We look for statistical significance. And this line, red line, is above which is not really explained by chance. So there are lots of dots above that. This is actually, I didn't really want to name them because it's a preliminary data, but there are already 2 areas in the chromosomes which highlights a couple of genetic variations which might co-occur in people who have got 2 or more organ fibrosis. I'll probably, if I have time, I've got another presentation on ethnic variation. So at that time, I'll show you real data. And so I've told you what we want to do. First of all, start with the single organ fibrosis, use the information, and then invite people to come to another study day if they are interested, and follow up and then find out what the outcomes are, and then develop a model as to how we can really identify these people before they get the second or a third organ, certainly, and how we can really change them. Eventually, this is one of the snippet of what we are already doing. This is a study which is ongoing. It needs 2 more patients, then we complete the recruitment of the study. So I promised you that we want to find a pathway. This is one of the pathway called mTOR pathway. This is very crucial pathway within the cell, which can trigger the stellate cells, these octopus-like cells or a star-like cells I identified. So we can block it by one of the medication we already use for transplant patients called sirolimus or rapamycin. And we are piloting a randomized controlled trial where we are giving it and seeing, well, whether people who already have a substantial scarring, can we reverse it? And we want to find more such targets through our study, so that in the future we can generate some treatments for it, so that we can prevent the second or a third organ getting scarred or reverse the first organ being scarred already. So I'll stop there and just end up with this great line which Mahatma Gandhi liked a lot: may all be blessed with wisdom. So this is data also from the same cohort I showed you as a first slide, which shows that one of the things that explains whether you do get comorbidity or not is really educational level. So we have already got an intervention, right? Educate more people. I hope this is part of it. Then you all are prevented by getting comorbidities, right? That is a good starting point. Thank you very much.
Amazing. Thank you so much, Guru. I mean, it's fascinating stuff. I mean, the potential to help people, and we're already helping people. So it's brilliant. Just looking at the time, we've got 20 minutes left, and we've got Chantal who's coming to. Yes, I knew it would happen.
She should talk.
If that's all right, and then if anyone has questions, can I encourage you to put them in the chat? Like I say, all questions welcome. And then if we have time at the end, then we'll take some. But Guru and Chantal and Esmond can continue to answer them in the chat as we continue to present. Does that sound okay?
That's good.
Excellent. So Chantal.
Shall I share my screen?
Yes,
Shall I share my screen?
Yeah, please do. So yes, we've got Chantal Kwame who's going to present on its ethnicity data, isn't it, relating to some of the work?
Yeah, I have some ethnicity data as well. I'll just stay on that alone then, basically. What's the thing?
No problem
I
at
think-
all.
I think I'm having some issues sharing my screen. It says host disabled participants.
Oh, 1 second. Oh dear. We just need to make you a co-host. Can you make Chantal a co-host? Well, I just.
Oh, dear.
Yeah. With you in a second.
Sure.
Okay, try now, Chantal. I'm so sorry.
Oh, it's okay. I'll try. See.
That should work now. You've been granted the rights of co-host. Hey.
Okay, can you see my
You now have the power. Apologies, everyone.
That's fine. Okay. Can you see it now? Or?
Perfect. Yeah, it's coming full screen. Yeah, got the nods. Yeah.
Okay, that's fine. I think I have it now. Okay. All right. Okay, so I am Chantal Comey. I am one of the hepatology research fellows, and I basically the person coordinating Demystify. Prof has said quite a bit about Demystify, so I'll go into ethical approval and chronic pancreatitis. And chronic pancreatitis is one of our cohorts in Demystify, and then I'll speak on the limitations that we're experiencing currently. So I'll leave out just broadly Demystify or multi-organ fibrosis study, which is really an observational study. And the cohorts that we're looking at are patients with inflammatory bowel disease, cirrhosis, chronic pancreatitis, chronic renal disease, and interstitial lung disease. So I'll focus on chronic pancreatitis, and chronic pancreatitis is basically when you have inflammation and scarring of the pancreas, and this replaces the parenchyma of the pancreas, and it causes exocrine and endocrine insufficiency. So I'll look at our presentation in Black patients, and this was a study done by Wilcox et al. And if we can. For some reason, I can't make the screen any bigger.
I think we can read it okay.
No, it is okay. Okay.
The Wilcox et al.
Yeah. So Wilcox et al., it was a prospective study, and this study looked at patients in a multi-center North American pancreatitis study from 26 US centers during the years 2000 to 2014. And during that period, they had 1,159 patients enrolled, and of which 248 patients were Black. And I think it's important to look at the ethnic variations, because these patients, they had different etiologies for chronic pancreatitis. Now, it's well known that alcohol is a major risk factor for the development of chronic pancreatitis, but it has also been proven that smoking is also an independent risk factor for chronic pancreatitis. And then we have other causes of chronic pancreatitis, including autoimmune causes, and also chronic renal disease as well. So in patients who have different ethnic backgrounds, the etiology tends to be different, the morphology tends to be different, and as well as the presentation tends to be different. So this is one of the reasons why we need patients from different backgrounds to represent. So we can see exactly how patients present from different backgrounds and the major etiologies as well. So in our study, Demystify, as I said before, it's mixed with, it comprises of patients from different cohorts. So we have ethical approval for our existing cohorts, and we achieved that on the 19th of July, 2023. And for prospective patients, we achieved the ethical approval on the 12th of September of this year as well. So within the chronic pancreatitis cohort, we are currently doing a retrospective study cohort, and this would form part of our existing cohort for Demystify. And when we looked at our population, our white population was 87.4%. So this is this chronic pancreatitis database of patients within the Nottingham catchment area. These are patients who attended Nottingham University NHS Trust hospitals between 2006 to 2014 and had CT scans, MRIs, fecal elastase that confirmed chronic pancreatitis. And in that population, our white population was 87.4%, while the Black population was 1.64% and Asian 1.37%. So very, poor representation. And currently we are contacting patients for chronic pancreatitis to take samples. Thus far, I've contacted 159 patients. 15 patients, we've been able to collect samples from 15 patients. 19 patients still have appointments to be arranged. So actually getting patients to participate in the observational study is actually proven to be quite difficult. So patients, for different reasons, don't want to participate. So that is one of our limitations. So limitations, difficulty with recruitment. Some patients are highly reluctant to participate. And then time constraints, because we have to get a certain amount of patients to be able to, so that it can be a true reflection of patients with chronic pancreatitis and what we can actually expect from these patients. And we only have a specific deadline in which to achieve this number of patients. I think that's about it. Any questions?
Wow. Lovely, Chantal. Thank you very much. Really interesting again, and it's great to see the additional work that's being had, although it's also sad to see that the historic cohort didn't have a proportionate representation of people who are affected. So I will not pose any questions myself. I'll save it for the audience. But we do have a bit of time now, so we can open the floor to questions. So Guru's reappeared. Shall we close the slides, if that's all right?
I see your question, Kate. You sent me in an email very politely. I'll answer that. Interestingly, I think the question from Kate was that what proportion of people, when we do a liver MRI scan, we see other organ scarring. So we have done a lot of the work independent of Demystify before, and the idea of actually multi-organ scarring started from our cirrhosis cohort, a study called 3CN, which we did in BRC some time ago. The way I can answer, I can't tell you about the proportion because that's not how we statistically analyze. How we analyze it is that, is there a correlation with cirrhosis to a kidney scarring, for example, right? Correlation is a statistical way of saying, well, this is not a chance occurrence. I showed you some of that with our UK Biobank genetic data. You might have seen that column of lung and liver scarring, how many times it can coexist, and is it normal or expected from a chance or not. In the same way, we have looked at liver and kidney scarring based on MRI, and there was a significant correlation between liver and kidney scarring. And we have now looked at UK Biobank data. So UK Biobank, we started from a kidney scarring, kidney disease data, or a kidney scan data, not kidney disease data, kidney scan data, and looked at, well, do they have something in the liver going on as well? And we have submitted an abstract for a MRI international conference. So it's not published, but I've got it in front of me and it has got lots of edit on it. But I can say that actually, if you look at people in UK Biobank who had an MRI of the kidney, for the kidney reason, Then you look, well, is there also something going on in the liver? There was a significant correlation between the liver scarring in people who have had an MRI scan of the kidney. So I've told you two ways. If you start with the liver, kidney seem to have scarring. And if you start from the kidney, liver seem to be scarred. So answer is in two different studies independently done. The UK Biobank is much bigger cohort. It seemed to be holding true. That's the answer.
Brilliant. Thank you, Guru. I mean, probably do a whole other session on the UK Biobank, because that is a perfect example of wealth of data and human samples for research purposes. So Hilary, has that helped answer your question? Don't feel like you have to.
Thank you very much. Somebody, Hilary. Yeah. Oh, right. Okay. You were asking Hilary. Yes. The number and proportion, I probably, when I see the raw data, I can tell and calculate probably in the future. But there is a message is that it's significantly more than you can expect by chance.
Yeah, absolutely. Thank you. So we have got
my question, there is a Richard Allen asking about, my question is on ALF blood test. Does this test just confirm fibrosis of the liver or present fibrosis? Fascinating, brilliant. So yes, I've looked at it as well. So I've just published a paper last year, well, not last year, 2023 actually, came online in a big journal called Journal of Hepatology, which was tweeted about 100,000 times. So this was a study I did to look at liver scarring in people who have got rheumatoid arthritis as well as psoriasis. Okay, 1,000 people nationally, 7 centers were involved. And we did the fibroscan, which is liver-specific scarring test, as well as ALF markers, which you are mentioning, which is a blood test for those who haven't been used to it. They contain 3 biomarkers of seemingly liver-specific scarring. One is called hyaluronic acid. Second one is called procollagen 3-amino terminal peptide. Third one is tissue inhibitor of metalloproteinase 1. So it's a panel. It's available now. It's NICE approved. It's widely accepted as a liver non-invasive test for scarring. And when we looked at people with rheumatoid arthritis, ALF markers seem to suggest that it's also telling about the joint and around the joint scarring. So if you are looking for organ-specific scarring, find out the organ-specific test. For liver, it's actually fibroscan in this indication, while ALF might be really looking at inflammation and scarring elsewhere as well. So that is the answer. So good question, very good question.
Thank you.
Lovely. Thank you. I mean, brilliant questions. We're not going to lie. Keep them coming. We've got a few more minutes. There's another one from Jane Guru.
Comments on here on a UK Biobank is not very diverse. It would appear that there are similar problems with your pancreatic cohort. If you do manage to create a truly diverse cohort or comparison, won't it be different from UK Biobank and others? Therefore, be useful for comparison. Yes, I accept. I had actually a full talk on ethnic variations. I was complaining more vigorously than you are, whoever it is. Jane. Oh, is Jane Grove, is it?
Oh, I'm not sure. It's
no, I'm Jane Paxton from DC Action.
Hi, yes, sadly. I mean, I was just going to tell you more fundamental problem is that actually genome, you probably know that, whole genome genotyping did not include sufficient ethnic diversity in itself, right? 40% of population is in Asia, and Asian genome came out probably later, not probably, it came out in 2020, and African genome publication came out in 2021. I had some very fresh data on African genome in my presentation. So if we are one of our focus is on genetics, and yes, UK Biobank data isn't diverse. but that is exactly things we need to address. So whole genome genotyping is really not whole American genotyping, right? So we need to kind of include people with true ethnic diversity. So I was kind of in that presentation, I was quoting one of the biggest studies in my own discipline, fatty liver disease study. About 600,000 people were genotyped. And the title was it is trans-ethnic study looking at genes which are polymorphism, which are variations which are related to fatty liver disease. Okay, so it had about few thousand, I think 1,700 or so African American people. So they're not really African people, it's African American people, second generation or a third generation. And it had 600 people from Asia. So this is 600,000 population study. So that is not trans-ethnic study. And to correct that, we need to actually walk the talk, truly get to people, get their trust to participate in studies. And it's our job to get the trust, not others' job to come and really participate in the study. So that is where I'll stop.
Yeah, totally agree. I think I feel another event coming on for maybe in the new year. That if you have that information, Guru, I can see another one already planned for us all. Oh, I think you're muted, Guru. Sorry.
No, I was just saying, yeah, I mean, I'm very happy to present that next time. Yeah, I think it was probably a bit too scientific, so I need to kind of make it a bit more acceptable and palatable for others. Don't want to bore people.
Well, thank you so much. We've got one last question from Hilary with 2 minutes to go. So let's try and sneak it in. So Hilary's asked, when can we get the ELF testing for those of us at known risk for multiple organ fibrosis? And does ELF testing apply in the same way to all ethnic groups? Double barrel question there.
Yeah, I would say that ELF test, first question I didn't ask, I mean, when do we get it for everybody, you mean, Hilary?
Yeah, I think that's when would it be available to people? Maybe
yeah, I mean, at the moment, there are two tests which are nice, approved for early diagnosis or community diagnosis or stratification of liver scarring. And ELF was designed for a liver scarring, and it is now widely requestable. It's a product of semen, and so that will be a cost attached to it, but it should be commissioned service. And most of the, I mean, I don't know how many practices are really using it, but we have it as a second line test if people can't have or don't get a reliable reading on a fibroscan for this. And there is, I would say, one credible study which had looked at ethnic variations in different biomarkers, liver non-invasive biomarkers. I don't think ELF has any problem with the different ethnic groups, but that doesn't mean that study has got a huge number of it. This was done in South Asian community in Gene and Health cohort in around London. So lots of Bangladesh community and South Asian community are in that cohort, and so it should be reasonable test for at least South Asian community. But I don't think I've seen a data focused on Black community yet. Yeah.
Okay. Thank you so much. I mean, that was bang on 7:30, so we'll finish on time. So I just want to thank everyone who's spoken at this evening event. So Esmond, Guru, Chantal, really appreciate you coming and presenting your work, and for starting the conversations, and everyone for taking the time out of your evening and how precious it is. So I really appreciate you all attending. So we will be in touch with a feedback survey via email. So if you could spare 5 minutes of your day to complete that, and let us know about any other topics you would like to see at an event like this. We really do want you to submit and hear what you would like to hear from us about. And as well, I'll just pop up a slide. So if you've got any questions after this, don't hesitate to contact us. So our worked? Our generic, our inbox for the team is, that works, yeah, is getinvolved@nuh.nhs.uk. So if you have any questions once you've left this virtual room, don't hesitate to contact us. Please carry on the conversation. And then here is our website, so you can sign up to receive newsletters, information about other events, involvement opportunities, and also just information about the research we're doing here in Nottingham. So that in mind, just want to thank everyone again and wish you all a lovely rest of your evening. Thanks so much for coming.
Bye-bye.
Bye-bye
Thank
now.
you very much.
Thank
Thank
you.
you. Bye-bye.
Bye-bye.
Bye.